Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back again to the 8-Minute Rule. We've got Drew and Mark here with me. We are excited to talk about the doctor title here today. Interested to get you guys' opinions. First, we're going to have a fun icebreaker. The question is going to be essentially, you're on an airplane, somebody turns around quickly and says, "Is there a doctor on the plane?" Drew, what is your answer? What is your reaction?
My initial reaction is depends what the problem is, but the joke I'm less serious. I'll probably most of the time, but if it wasn't an emergency, I would probably just say, well, not a real doctor.
Mark?
I think my initial gut reaction is like, well, maybe. Who's asking? Like, what do you need? I think my first reaction would probably be like, okay, let me see if this is what kind of like, if I'm the kind of doctor that is needed for this situation or not. I wouldn't necessarily just hop up and be like, yep, I'm a doctor.
I think that's probably a wise stance there. Yeah, so the one of the things that brought this up for me was we had situation that I'd read about on LinkedIn this weekend where a physical therapist was out at a soccer game and apparently somebody had fallen. It was an 85-year-old had fallen in the bathrooms and hit her head and some other things. And somebody had come out asking for, are there they said, any doctors or nurses or anything like that? And she gave the same response you mentioned, what is it? And they brought her in there. And so she was able to kind of take the vitals, address, was she on blood thinners? Her hip was kind of bruised and she had a nice little lump on her head, and so she helped patient get to the car and advised him to go to the ER to rule out pelvic fracture and concussion as well. And it was just one of those good reminders that we do have a lot of skills to bring. And to your point, let's ask what and see if we can, at least our healthcare prowess can be beneficial in the situation. Obviously, we don't want to overstep our bounds on that, but there's a lot of things that we can be really helpful in. So great. I appreciate you guys' perspective there. So what we're talking about today, essentially, the use of the term doctor. So because I know you guys are really excited to know the history of the context of doctor, I'm going to actually share a little bit. So it goes back to medieval Europe, linked to theology, law, and medicine. It is a symbol of intellectual authority, and over time it expanded to include many academic disciplines. Some of the impacts we've seen in society: enhancing credibility, enhancing trust in healthcare. Some say also can advance inclusivity. However, doctor is often assumed to mean physician. APTA supports the use of physical therapists in labeling themselves and introducing as doctor, provided that transparency is included to clarify that we are not a medical doctor. So I would like to throw it over to you guys. Mark, should we be introducing ourselves as doctors?
Honestly, on this one, I can see both sides of the argument, and I don't have necessarily strong opinions one way or the other, and meaning I could be swayed. I have done both. I don't, in my current practice, usually introduce myself as Dr. Powell. However, in my previous setting where the health literacy was a lot lower, and people generally had less knowledge of what physical therapists are/do, introduced myself as Dr. Powell, but I always followed up with but you can call me Mark. I think there's a time and a place for both. I think when we're talking to other providers, I think there's something to be said for saying, hey, I'm Dr. Powell. Again, if you're trying to become more familiar with that provider, I think it's always good to follow up with hey, you can call me by my first name though. But that's just my kind of initial impression to the question there.
Yeah, I like the thought process around setting dependence. Obviously you're going to have a broad variety in terms of the person that's in front of you. So, Drew, what's your initial thought?
Yeah, the controversial "it depends," I think, is a pretty accurate description there. I have no problem with people introducing themselves as doctor, whatever, as a physical therapist. I'm the same as Mark. I typically don't. For several reasons. One, I think that it can be a little bit confusing just in the medical community. If if everyone is using that term. And just, again, in the setting, depending where you're at, it may make more sense. We're in a very big medical community here with some big hospital systems and things like that. So the healthcare literacy is probably a little bit different. So I will typically not use that. I think we should talk less about it and be more about it. And so present all the actions, the screening, all the things that you do as a doctoring profession. So I think one of the best compliments I sometimes get is, after I go through a thorough examination, a thorough subjective, thorough objective, they're like, wow, that was pretty thorough. That's like what a doctor would do. And I'm like, well, actually, we are doctors. We're doctors of PT, so it's different. And then you can start educating them a little bit more about it. But when somebody sees it, I think they're going to recognize it, and that's more valuable to me than I think the just the term doctor. So that's my preference. Same as Mark. If I'm calling up a office and I'm sharing some information, something that's important, I want to get it to the referring physician or whoever the referring provider is, I tend to use, hey, this is Dr. Drew Slabaugh, I'm a physical therapist at Breakthrough, whatever, because that does seem to carry a little bit more weight. And I think with all of the communication, especially if it's something that's really important, it can tend to get lost because from one, their what are they called? Their medical assistant to the next person. Sometimes it gets lost, and it does carry a little bit more weight. And we do have a prominent place in care with patients, especially musculoskeletal care. So I have no problem using it, and I tend to get a different response in the medical community when I do that versus when I'm working with patients. I probably won't, and I want to probably be a little bit more be about it versus just talking about it.
Yeah, big fan of don't talk about it, be about it. I think that's a really good piece of advice if you want to break it all down to it. One of the other things I thought about in general, I mean, we know chiropractors, dentists, pharmacists, podiatrists all kind of have at least the label and typically known introducing themselves as doctors and from patients as well too. I think through how much that benefits their field, and do you think that's something that could benefit the field of physical therapy at all?
I mean, I think there's potential there, and I do want to also qualify kind of our impressions so far from our perspective is we are all white males too. I know that, and I've seen it in the clinic before, that my female counterparts don't sometimes get the same level of respect just because of their gender, and similar with minorities too. So in my previous clinic, that was something that I had noticed more often than I would have liked. And so I started to introduce myself as doctor as well, because I wanted to make sure that we were all on the same page, and so were our patients on who we are and what we do. And so as a profession, I think there could be some value in being consistent across the board. I do want to make sure that I'm not creating another barrier or level of authority between me and my patient. I want to have a working relationship with them. I don't know that having that label is the barrier, but it can create a sense of oh man, I can't joke around with this person sometimes.
Yeah, I think that's helpful. I kind of drifting back to the inclusivity side of things and trying to remove a barrier there. Any thoughts, Drew?
Yeah, well, that's a layer that I didn't think about it with the term of doctor as much until you just said that. And it reminds me of a recent patient that I've had that care switched over from one of our other PTs to myself. And there was a definite difference in the way that the person responded to her versus me, because I had been mentoring her through some of it and giving the exact same suggestions. And when I started giving them, he started listening a little bit more. And so I think it makes me stop and pause a bit and be like, maybe I should, and encourage my other PTs to do that as well, instead of just thinking about how it affects me. That's a great point.
Yeah, I appreciate you guys taking it there. I think that's a good thing that we can think about in our own clinics, and obviously the physical therapy profession as a whole as well. Kind of zooming back just a touch for one kind of bringing home point. I know you guys have been a part of plenty of conversations in your clinic where somebody comes up and just says, my neck hasn't been getting better in a couple visits. I think I need a doctor to check it out. And, granted, we've got orthopedists, we've got PAs, we've got physicians in internal med, family med, urgent care across the spectrum. How do you go about kind of with that conversation in that moment with that individual that you can see there's a very clear divide in their mind between the term doctor to check it out and what we are? So how do you go about in that moment with really trying to create buy-in with that individual?
I think finding out what is their big concern is the key. There are times when referral is absolutely needed. Maybe it's just because they need some confidence, and if you get that psychosocial component, like, okay, let's get another person on this team with the idea that they're probably just going to back me up. But if they get it from another person, maybe that's good. But I think more importantly is the getting to why do you feel like you need to see someone else, what's not getting better, and then you can kind of dive into it with them. You can problem solve. You can say, well, here's what I think and here's why. And sometimes they'll be like, oh, okay, that does make sense. Let's go down this path. And sometimes it's just not gonna work, and you're like, okay, well, let's get them in here, and then you can call, refer them out, talk to that doc, and have some conversation with them around, what's happening, what do you think's going on, and again, work together as a team.
I think too, hopefully I've done a good job on the front end of like making sure that they're committed and make sure that I've educated them well enough. Sometimes I'll use the shared decision-making process where I will lay out their options for their health care. They can do nothing at all, and that's totally an option for them. They could go see this doctor and they could get an injection, they could do all these other things, and these are the outcomes, these are the risks associated with those. And then my preferred option in most cases is coming and working with me. This is what that's going to look like. This is how long I expect it to take. And then ultimately put the decision on them. Those are your options that I can see right now. Where do you want to go? What do you want to do? And then that forces them to commit to a plan of care, essentially. And then if you have a conversation, a couple weeks down the road and they're not getting better, okay, do we need to revisit that shared decision-making process? Do I need to change something because I've missed something? Or that's just a very different conversation.
Yeah, I think that's great stuff. Some of the best patient relationships that I have right now are because I've actually referred them out and I've been able, we've taken a step to create that shared decision process because they still see me as somebody that took enough time and interest and thoroughness in their evaluation to make sure that we got them in the right place. I think it all comes down to, is our pride in a place where we're more concerned about getting outcomes than we are necessarily at us or us being right as well too. And Drew, I like the point that you mentioned up. Sometimes, again, people just have something stuck in their head where I got to get somebody else on the team that's probably going to say the same thing, and it's a great opportunity for me to build a provider relationship in that moment as well too. And end of the day, the patient ends up getting better, and so I think we can all kind of lay that down. But I love your phrasing around the "don't talk about it, be about it." I think that's my biggest takeaway on this. You got something?
I think one of the things that if we want to be kind of considered one of the primary providers of musculoskeletal care, part of that is helping them navigate the medical system, and that's having those relationships and helping them guide with other providers and giving them the other providers our findings and our stuff so they can take it from there as well. So there's a big responsibility in that when you start seeing people in direct care and wanting to step into that space.
Well, good stuff, guys. As always, until next week, we'll see you.